Right, so first things first, my name's Clement. Ryan, but call me Clement, or everybody calls me Clem. I'm an osteopath. I specialise in nothing and everything. So I specialise in causality-based examination and treatment. And I teach that to osteopaths in university, to the undergraduates, and then postgraduate training. So it's just a niche part of osteopathy, and that's where I found my passion in tracking down causality within the issues that we all have, including headaches and migraines. This is a nice one because it's, as most of you probably know, it can be really quite debilitating. And we can get temporary relief with different treatments, or sometimes makes it worse. So it's nice to be able to have more permanent and frank results, which is what we tend to have when we look at causes, rather than effects. God, this is really loud. We can't change it. I can press one button, the on-off one, the rest is locked security system. Okay. So you can ask your questions whenever you want. We'll try to have 15 minutes at the end, questions and answers. So I sort of apologise for the old-fashioned stuff. I write on my little thing there and there's a projection that happens, but we need Wi-Fi for that, and the Wi-Fi said no, not tonight. So there you go. So we're back to the old-fashioned, pen and paper. Okay. So yeah, I'm very new here. This is my first presentation. I love teaching, and hopefully one of many. We've just arrived in Frome a few months ago. And I'm impressed, by the way, by many things in Frome, and the numbers in which you've come is one expression that Frome's such an amazing place. I did the same in Haverfordwest, so southwest Wales, and I think there was 12 people that came, maybe less, maybe 10. Right, headaches and migraines. Tell me, what do you know about headaches and migraines? Go on then. They're horrible, yeah. Depends on what you have. What sort of headaches and migraines do we have? Go on. This presentation's yours. I've done this many times. Optical migraine. So you've got migraines. We'll go into all sorts of details, but for now, yeah, migraines. What sort of migraines are there? So you mentioned optical. Any others? Chronic, yeah. Any others? Say again? Hormonal. We call it, menstrual. Any others? Wow, stress migraines. Yep.
Ones that go on and on and on and on and on.
Yeah, so migraine is very long ones. Well, yeah, migraine's already too long. So the official, can you read at the back? Sorry. Is that, yeah. Yeah, is that okay? I'll write a bit bigger. The definition of a migraine is a headache that lasts between 4 hours to 72. So if it lasts 3 hours and 59 minutes, it's not a migraine officially. That's it, 3 days? That's the maximum apparently. If you're just better today. Okay, good. Hopefully you can focus. Any others?
Food stuff.
Say again?
Food.
Food related.
Yeah.
Okay. Dietary.
Sleep deprivation.
Sleep deprivation, yes. Okay, I'm going to put insomnia. Any others?
Hemiplegic.
Hemiplegic migraine, okay. Hemiplegia. Right.
Headaches are on one side of the head, on the eye,
Yeah, exactly. So what's this called? Yeah. You know, I'm quite surprised you've come up with all these things. But medically speaking, so if you come here and you see a professional here, doctor here, they'll want to put you into one of the three categories. Does anybody know? Cluster. Two more?
Tension.
Ah, no.
Stress.
Oh, we got that there. Different thing. Yeah. I'm going to put here sensory. Common migraine, have you heard of that? Okay. So that's one. So that, oops, sorry, I'm dyslexic. There should be 2M. Common. And then the last one's classic. Have you heard of these? Cluster, common with 2M's. And going classic. So that's what the doctor will want to do first and foremost. Like, okay, which sort of one is it? And then, well, let's give them the same medication anyway. But it sounds better if you have a closer diagnosis, if it fits a more medical picture. So that's actually the main three. Okay, the main three categories. And then there's a new one, a new term of migraine that comes out every year. But yeah, we've got menstrual, that's become one of the categories. And for some reason it's escaped me, it's kids migraine. And it's not called juvenile, it's called another one. I'm just going to put kids. Okay. Okay, cluster migraine, typically, it's pain behind the eye, one eye usually, can be both, but it's very, very intense. Very intense pain, usually patients want to hit their head against the wall. That's cluster migraine. Same thing, it lasts for a while, too long. Common migraine tend to be more the whole head. Okay, classic migraine typically is unilateral, so one side of the head. And usually is the classic one, could be the common, but usually the classic one that comes with all the migraine-y type fun symptoms of photophobia, so sensitive to light, sensitive to noise. So yeah, that's it. Sensory that you said earlier, smell and even motion. So a lot of these people like to just go to a dark, quiet room and hibernate for 72 hours. Does any of you do this? Yes? Yes, a few. Okay, oh, you do that? Okay. Right. That's useless. All of this will be written down. And I'll show you why. But I'll tell you now, this has got nothing to do with causes. So none of it's got anything to do with causes. So we can focus on that. And this is the official classification, but it doesn't help us to go towards the cause. So it doesn't help us going towards resolving the issue. So dietary, like coffee, chocolate typically, could be other things, gluten. That's a trigger, in fact. Yeah. I usually do another thing, but I think we'll, yeah, that's more trigger. I can eat chocolate and not have a migraine, usually. Most people can eat chocolate and have migraines, but some people eat chocolate and it starts a migraine, or go around the mountains, have a lot of motion, and that might set off a migraine. But most people won't have a migraine, so it can't be cause, since it's not causing it. But it's somewhat of a trigger. So actually we are going to do the other thing. Okay. So that's the most important. What's a cause and what's a demand? Because I just see that all the time. Patients come in, it's like, oh yeah, my back is bad, I know what's caused it. I bent down and picked something up. That's what's caused it. And for me it's always like, well actually that's not what's caused it. That was definitely the trigger, but that's not the cause, because everybody bends down all the time to pick something up and it doesn't come up with back pain. So, humour me. See if you can give me some causes.
Genes.
So we've got genes. Oh, genes is always an annoying one. Has to be the first one as well. I'm going to have to put that in the middle. If we have time at the end, we'll go into that, okay? That's be a presentation in itself, but yes. So we spoke, what did you speak about? Dietary. Okay, so that's a demand. Okay, it's not everybody who eats gluten who has a migraine. Anything else? Hormones. So like the menstrual cycle, you mean? Very good. So it's not every woman, when they're due, that starts to have a migraine. There's PMS, that's one thing, premenstrual syndrome. But the migraine ones, they tend to come on when periods are due. So again, hormones is a hormonal surge. It tends to be a challenging time, but it comes in different ways with different women, doesn't it? I have a colleague, an acupuncturist in Wales. She manages the clinic, and she always makes me laugh because when she's due, she's full of power and ideas and proactivity, and the clinic is going to change it to something wonderful. And I see it a week after. It's like, no, we didn't do any of that. I was due for my periods. So all these insights and ideas came in. You know, others like to hibernate. Others feel sensitive, irritable, and don't touch me. Or so it comes. It's a demand at that time of the month. But again, not all of you in this room, when they're due, have a migraine. So it's a demand. Go on. More.
When my neck feels
Yes. It's not. I've jumped a little bit. But we'll come back to that in about 5 minutes. So give me other causes. What could be the cause of a migraine? Yes, go on. Such as? Yeah. I'm going to put it there. No, it's true, because it's both a demand with the physiology that's happening, but it can also contribute in the causality. It'll become clear, hopefully, in a few minutes. Anything else?
Injury?
Injury. What sort of injury?
Could be a back injury, could be a leg injury, could be a shoulder injury.
Wow. Nobody ever comes up with anything in that column. So, an injury. Yeah, so I'm going to put it actually here. Because. And you'll bring it. No, but this is great. This is juicy. This is fabulous. This is the stuff. Because you can have an injury. So, a whiplash. Somebody bumps in the back of you. They were looking at their phone and they bump in the back of you. So you get an impact through your body. So you've got 7 vertebrae in the neck. The whiplash always affects the C5. Just mechanically, that's the way things are set up. As you get bumped, the head goes backwards and it strains the C5. So then you get an injury. For some people, that will be problematic for the rest of their lives. For others, it won't be. Okay? Now, there can be different grades of impact, but it's generally the same rule. So you can twist your ankle, and then your body will lock this impact in, and there will be tension within the ankle as a response to the impact, or not. So injury can definitely be part of the whole if the body feels that it's necessary to react to it. So you can twist your ankle, 3 weeks later, your ankle's 100%, or you can twist your ankle and it never goes 100% until somebody goes in there and manipulates it and makes it better again. So injury, yeah, could be. Anything else? Yes? Dehydration. Yeah, that's definitely a nice demand. Sorry. Okay. Dehydration. And that can cause the dehydration headache, which is not a migraine, but yeah, dehydration, everything starts to shrink. So the tissues in the head are also shrink, and that can pull on certain things and cause headaches. And maybe, as that happens, it might spark off a migraine process. Anything else? Yeah. Oh, go on.
The weather.
Yeah, the weather. Humidity, particularly? Yeah. Or heat, yes. So I'm going to put humidity. Why?
Dehydration.
No? No, because there's loads of water in the air. If you're in the Sahara, then yeah, you'll be more dehydrated quicker. Because humidity means there's more droplets of water in the air, which means more pressure onto our bodies. So, and that just creates more pressure. So if there's already a predisposition, which we'll get in this column, then more pressure, atmospheric pressure, might trigger a migraine. It'll trigger loads of things. So, you know, somebody with osteoarthritis of the knee, that will also make it worse because they'll put pressure onto their knee. The knee's already in trouble. They put pressure, it makes it worse.
Can you explain the difference between cause and demand? I don't understand what's meant.
Yeah, well, no, hopefully you will now. There's just one thing. Yeah, that's fine. Coffee. Some people are affected by coffee.
What about lacking in?
So again?
What about lacking in a mineral?
Yeah. Yeah, that'll be a predisposition. We're looking at this sort of stuff. Dietary could be irritating food, or there can be a lack of resources, which is then the minerals. Yeah. Very good. Say again? Medication, yeah. Usually medication doesn't cause migraines, even though it can cause certain issue, a bit like injury, but it tends to be a right demand on the system. Meds. Right. No more. Yeah, what about the nervous system? Could you injure it? Yeah, of course you could.
Stress, anxiety, that sort of thing.
Stress. Stress is a demand for anything and everything. You know, everybody's, you know, sometimes, again, see patients like, oh, I know what causes it. It's stress, because when I'm stressed, I'm worse. You know, my irritable bowel is worse, or whatever is worse. My blood pressure is worse. But stress really only causes one thing, and that's adrenal burnout. So stress causes stress hormones to be secreted, and if it's a bit like diabetes, once the gland wears out, because it's been overworked for so long, then you get a condition. So for the pancreas, it'll be diabetes. For the adrenal gland, it's adrenal burnout. So that's what stress causes. Anything else, it just demands more onto the system. Now the cause, I just found a nice wording the other day. The cause is simply what, or the thing that disturbs proper function of the tissues that are causing pain. You're probably all going to be disappointed now. You wanted something really specific. This is as specific as it gets, which hopefully you'll understand before you leave. It's both it's both wonderful and frustrating at the same time, because there isn't one cause for all sorts of different. So there isn't one cause that gives us one expression, because we're all very complex and all very different. But there's definitely got to be something that disturbs any tissues that's giving us pain. So with migraines, nobody knows what's causing pain with migraines, but the most plausible theory is the constriction and dilatation of the blood vessels in the brain. That's bits that are quite pain sensitive, and it's all over the brain. You can get one-sided innervation, so nerves on the right side of the spine go up and innervate the right side. Blood vessels, left side, same thing. So it could be both sides, or it can be one-sided. But that seems to be the most plausible theory. So what is it? So the cause really is, what is it that disturbs If it is the blood vessels, for example, what is it that disturbs these blood vessels? And it could be all sorts of things, which is why I can't just write something. So yes, it could be an injury. Like we spoke about the C5 in here. So the nerves that innervate these blood vessels or anything in the brain is plexus in the neck, the cervical plexus we call it. So it goes into nearly all the vertebrae in the neck. Doesn't go to the first two, C1, C2, but it goes to C3, C4, C5, C6, C7. Okay. So C5 issue. If it becomes an issue, I'll definitely feed into the neurology in the spinal cord to get to the brain, to tell the brain we've got an issue in the C5. And as it does, it may irritate some of the nerves that go in all sorts of other places, including the brain. So we've got the neck, and for the brain and head and face, we've also got T1 to T4, the top 4 vertebrae in the back. So for any head, face, or neck or throat issues, these areas have to be jeopardized, which we'll go into now. Oh no, we won't. I forgot something. Is that okay so far, or is it getting confusing? Should get a bit confusing, and then it should be clearer. So we went straight into migraines, but this is also about headaches. So what other headaches do we have? Someone mentioned tension, didn't you? Was it you? Yeah.
Is that physical tension or just another word for stress?
So that's actually mechanical tension, and it's usually just neck. So you've got muscles in the neck and trapezius. They go and attach into the back of the head, the occiput, the bone at the back. At the attachment point, there's another muscle that attaches there called the occipitofrontalis that goes all the way. So it's very thin muscle that's over the scalp, under the skin, obviously. And it's very thin, and it anchors right at the front there. So tension there pulls on the attachment point, and then tension is communicated throughout the muscle. And the muscle being tight itself can be responsible for the pain, and that's what we call tension headache. So sometimes, yeah, stiff neck. People usually mention something with their neck. It's like, oh yeah, well, yeah, it can be at the front, the tension headache. Could be one side, could be both sides, could be all over, could be just at the back, because the muscle is all over the place anyway. Okay, and that goes almost hand in hand. This is a little bit confusing with cervicogenic. So it sort of originate from the neck. Headache originate from the neck. So it could be muscles, tension headache. There's 2 nerves that come out right at the top of the neck that innervates the back of the head, called the occipital nerves. In theory, they could be impinged. I say in theory, because I've never seen that in practice. But they're there. The nerves are coming out through muscles, the suboccipitals. In theory, they could be impinged and cause pain. What other headaches do we have? Ice cream headaches? Yeah, so we mentioned dehydration. Cluster, that's a migraine. So I'm thinking, yeah, we've done the migraines. Other headaches. Can your sinuses cause headaches? How many sinuses do we have? 4, yeah. Which ones is it? Maxillary and frontal. So there's 1 in the frontal. Does anybody know where the 4th one is? On the side?
Yeah.
No? Oh. It's actually right in the center. Is that going to be okay? Film crew. It's actually right in the center, in the sphenoid bone. Have you ever heard of the sphenoid bone? Just a bone. Right in the middle there, it's got 2 wings that goes to the outside. That's the bit we can feel. And then the bone's in the middle. And in there's actually lots of sinuses. And usually people who have got sinuses, it's painful more in the face, could be more in the frontal bit. But usually on an MRI scan, we can see that the sphenoidal sinuses are full of mucus. So sinusitis, and it feels like congestion, generalized headache. So sinusitis, and it's worse when you put more pressure. Typically people bend down and they go, oh my God, if I bend down for more than 5 seconds, the headache gets worse. Anything else? Any other headaches? TMJ, yeah. So TMJ can refer pain in all sorts of places. It can refer pain with the neck. It's always connected with the C2, I find. But it can typically give pain higher up in the head.
So Sorry, what's that?
Oh, yeah, sorry. TMJ is the temporomandibular joint, which is just the jaw joint. But it's a buzz joint, so everybody knows it by its Latin name, temporomandibular joint. It's a bit like fascia, that's another buzzword. Everybody, nobody knew about fascia about 10 years ago, now everybody does. Anything else?
Tiredness.
Yes, tiredness. Yeah, we've got ice cream. Can't spell that. Insomnia, we went into that before. That could be a trigger for a migraine, or it could just give somebody a general headache. Okay, let me just have a look if there's anything important that we should have said. No. Okay. So that's just about the tissues causing pain. However, all of this is a different process to the migraines, because they don't have to last 4 hours to 72 hours. Okay. Now, causes, that's why we're here. So what was what I put on the left column? What? Causing pain, yeah. Very good. So what disturbs it? So, before we go into that, we have to talk about osteopathy. And then you'll be able to answer that question. Okay? Has anybody seen an osteopath before? Got 1, 2, 3, okay. Half the room, okay, that's great. What do they do? Or what do we do? Click bones? Treat the bones? Yeah. Apparently. Or at least that's how it's taught. In order to be an osteopath, you've got to be able to click bones. Otherwise you can't be an osteopath. So that's the basis. So what I did, I went back to the roots as much as I can, looking for answers, because I wasn't quite happy clicking bones. And that's how, I came more with a causality understanding. And there's lots of other osteopaths that also do it. But most just click bones, because that's the basic training. So what does it mean? Osteo? Yeah. And what about pathy? Yeah, condition. What's another name for condition? Yeah. And the root of the word disease is dis-ease. Which sounds stupid, but what is dis-ease? It's the opposite of being in ease. Okay? So that means not in ease. So bones are not in ease. And one can make a bone not in ease. What can make any tissue in the body not in ease? Yeah. Yeah. So, dis-ease, first of all, is all about density. So if you're in ease, like nice weather today, you can walk out, it's like, this is lovely, this is ease, you expand. However, if you walk out like it was last week, and we went to Wales at the weekend, it was even worse over there. Yeah, that doesn't feel at ease when you leave the indoors. You go out, it's like, all right, this is umbrella, this is full-on protection. And you're like, oh bloody hell, rain, I forgot my jacket. So that's the opposite of ease. So that's contraction. If you're having an argument with somebody, he's not making you feel good, or she's not making, again, you're not in ease. Whereas if you're having a good laugh with somebody, you're in ease, you expand. Ease, expand, dis-ease, densification. So a muscle, to densify, contracts because it has contractile fibers. And we tend to think only of muscles that can do that densification, to contract. Because densification is just matter, more matter in one space. That's all density is. So like the carpet is less dense than a chair, because the chair's just got more matter. That's just, basic physics, okay? So dis-ease is all about densification when we look at the body, okay? So muscles can be dense, and bones can be dense. And that's what we call osteopathy. When we feel the bony structure and we think, oh, there's something dense there, there's osteopathy there. Okay, oh, there's something dense there, there's osteopathy there. That means there's something not right somewhere. Okay? However, the question I asked earlier, I'll ask it more specifically, what is the system in the body that could make something go dense? Whether it's a muscle, a bone, an organ, the skin, a joint. Yeah, wow, nobody ever gets it first time. And this is the key. The key to osteopathy. I don't know why he didn't call it neuropathy, and he called it osteopathy. So, no, I know why he called it osteopathy, because this innervates everything in the body, all the tissues. Okay, so a nerve that goes to a tissue dictates what that tissue does, whether it does nothing and it's in ease, or whether it does something and it's in, either it's functioning fine or it's in a state of dis-ease. Okay? So that's the key. And all we do is that we use the bones to work out what's that bit saying. And why that's important is because the neurology, peripheral system, autonomic nervous system, and central system, so all the nerves, the brain, knows everything. It has to, that's why we have it. Okay? Picks up the five senses, picks up everything. All the information from the outside world that we need to understand and interpret goes into the neurology and goes up to the manager, up in the brain. Okay? And the brain doesn't just pick up information, it also reacts. And it makes sense that that's the one that reacts and decides what's going to be tight or densified or in dis-ease and what's not. Because it has all the information and can work out the most optimal state of being. Is that okay? In that given time. And that's why you can twist your ankle, and for that one given person, their personality, their genes, their upbringing with their parents, their upbringing by their culture, the amount of issues that they already have in their body, that their neurology is creating, all that complexity results in the current state, and then they twist their ankle, and they can have a problem from there or not, depending on them. Because the issues, the bone dis-ease, only happens out of necessity. And the only necessity in this world is surviving. That's why we're here as humans. I mean, this stuff is old. This is as old as, in the start of our evolution, before before mortgages were there and things that we feel are necessary. It's all about survival. And to survive, you need to learn. Yeah, if you cross the street and you almost get run over, not here in the car park probably, but you'll quickly learn that, okay, I better look left and right before I cross the street, otherwise I could die. So it's all about survival. So that's a learning thing. So if we have inputs in the body, so impacts, and the body feels, whoa, this is too much for us, we need to have a learning outcome from there, because that's information from the outside world that jeopardized our survival. And it's all about the threshold. We can say the threshold of comfortableness, or the threshold of resiliency, I like to call it. And that threshold is different for different people, from what I explained, the personality and the issues they already have. Okay? So if you twist your ankle, say you're here, you twist your ankle, I'm going to use a different colour, and it doesn't go beyond the threshold of resiliency. The body's like, well, we just had an injury, that happens, no big deal. Let's heal it, and let's never speak of it again. So the ankle heals up, and then there's no traces that happened in the body, because the neurology didn't react, because it didn't go over the threshold of resiliency. But if it does go over, then we'll have something that happens. So all that happens, the neurology picks up the information, whoa, the force is going through the ankle. No, this is too much. This is jeopardizing our survival. We're going to react to this. So because in this world we twist our ankles that way, let's twist things the other way so that we're better prepared next time that comes along. So back to the whiplash, you're driving, somebody bumps you in the back, so there's an extension that happens, that's extension, that's flexion. Maybe you were looking in the mirror as well, so there's a bit of rotation. You were looking in the mirror, rotation, and then you go into extension. That's the input. If it goes above the threshold, neurology goes, no, we're going to remember this. And it shifts that one vertebra that's getting all the strain, the C5, into flexion and right rotation. And it gets locked in there. Inside the bone, and in all the other tissues. All the ligaments, the fascia, the muscle, everything. And from there, and this is the key now, from there, so we've got a problem in the C5. You can see some osteopaths or chiropractors go, C5's tight, let's whack it. There you go, now it's sorted. So cracking things just release a joint, and that's it. So it just forces the joint to release. But doesn't tackle with any tension in any of the tissues, including the bone. And the bone, the reason why it's so important is that because the bone is the one tissue we have in the body that's the highest in matter. So an organ will be like the carpet, and the bone will be more like the chair. There's much more matter in a bone, and therefore a bone can accumulate much more tension. Okay? And so it will. And usually if we adjust somebody, so if we crack somebody's back or vertebra, and especially if that tension's necessary, the tension's forced to go out of the soft tissue, but if that tension's necessary, it goes into the bones even more. So we test the joint. Wow, this is really flexible now. I've just cracked this joint both sides. It's made a lovely noise. Now it moves. Fabulous. But nobody tests the density of the bones. I don't know why, but nobody does it. So yeah, as far as the practitioner is concerned, job down. Patient goes, oh yeah, this is looser. Within half an hour, it all starts coming back. Not 100%, but it begins. And, a lot of people after a week, or it lasts a couple of days, and then, yeah, it was great, but you need to do it again. And then again and again, and there's more and more tension in the bone that accumulates. And then that essentially becomes a problem. I saw one last week, actually, a patient who's been too many times to see someone who cracked them everywhere, hundreds of times. And it was really tricky treating him. We found loads of issues, but we also had to treat a lot of bones to undo what was done. Anyway, so anything that causes disturbance of the tissues, this is the stuff that can do it. We spoke about twisted ankle, we spoke about whiplash, but any impact of any nature in the body, if it goes beyond the level, the threshold, the neurology will go, right, we're going to remember this. Oh yeah, and before I finish, so C5, we said is twisted that way, will mean that the brain will go, well, we're not just going to have one vertebra completely twisted that way, we're going to compensate with one above and one below, and the shoulder girdle is going to do that, and the pelvis that, and that leg's going to twist, and this arm's going to do that, because it's a whole. You had the brain's at the head of all his body, and it goes, yeah, we're all going to share the load. And there's 3 trillion cells in there. It's not going to be just, one vertebra that's going to be buggered. It's going to be, we're going to share the load throughout the whole system, because that's more efficient. If we think of a CEO, a managing team of a company, they'll do the same. Okay? Right. So we can examine the whole bony structures, find all sorts of issues, but then the key question is, why is it there? So if we have a C5 issue, there'll be issues then throughout everywhere as a compensatory measure. So we need to interact with something that will lead us, in this case, to the C5. So we can treat the cause and not the compensations. So, in order to do that, we get to the next page. The neurology is our friend. It's the inside man. 6:45. Yeah, we're good. We're good. It's the inside man. It's the messenger. Okay, so I might say something before I go into this. No, I won't. Right. What do you think that is? Yeah. I treat horses half the time, and when I do horse presentation, it looks a bit different. Then nobody can guess what it is. So, right. We spoke about the ankle, where the impact that came into here. Okay. The nerve of the ankle tends to be the L4 nerve. Oops, sorry. L4. Now, this is the key. Unfortunately, most osteopaths don't know, which is why I teach this stuff to osteopaths. Okay. So we've established it's gone above the threshold of resiliency. The neurologist decided, right, now we're going to remember this and we're going to lock things in the opposite direction, so it's better prepared. You know, do you understand all this, do you? You know, if somebody's coming at you, you're going to brace and, you know, almost go into it. Okay? If you don't, it'll be much easier to knock you over. So it's just offense is the better mode of defense. So when something happens, I know this person, they were horrible to me. This time I'm prepared, So this is the same thing that happens. It's like, okay, that's happened, now we're prepared. So we're tight in a protective way, in the opposite of what happened before. So L4 nerve goes into here. Now, what do you think happens when the L4 nerve, so there's 5 vertebrae in the low back, L1, L2, L3, L4, L5, and then the sacrum. What do you think happens? It synapses, so it stops, and then what happens? So what are nerves? Pathways of messages. They're like phone lines, okay? But they work with electricity. And that's the key about nerves. It's all electrical. So there's the whole system, the histology, the way nerves are made is to conduce electricity better and faster. It's got bits of fat in there, myelin sheath around nerves to help the conduction of minerals flowing through. A charged particle that moves, that's a current, that's electricity. That's all it is. So they're just, they're just the phone lines. So there's somebody who's picked up the phone there and goes, oh my God, you won't believe what happened. So there's a lot of electricity all of a sudden going through the nerve. It stops at the spinal cord. So it goes into the vertebra through its little gap and then stops within the spinal cord and goes, oh my God, you don't know what's happening down there. So it's like somebody's calling you, you pick up the phone, oh my God, you don't know what's happening down there. And all the nerves, which are excited, all the neurology at that level, which is excitable, it's just waiting there, waiting to jump, to do something. They're already doing things, but it's all about electricity moving. So you come in, it's a bit like the frog leg sort of experiment we used to do in biology. Put a bit of electricity and the leg twitches, because that's the muscles. But this is the same thing. Electricity goes in, and the whole area which is already preloaded, it's excitable, it's all about electricity in the nerves, so especially in the spinal cord. That all goes, oh my God, what's happening down there? And the whole area gets higher in electrical load, or we call it neural load. And the term for that is facilitation. It's an osteopathic term, facilitation. Which means at that level, so if that's the spinal cord, at that level, that segment has got more electricity into it, more neural load. So if it has more neural load, this is the sensory input. If all this has more neural load, what do you think happened to the other part? which will be green. So we got sensory and we got motor. Motor means action. So the information goes into the R4, excites the whole level there of the spinal cord, and then goes up to the brain to tell the brain, oh, you know, the right ankle's not doing good. Just had an impact there. You've got to do something about it, adapt the whole system. But before it gets to the brain, something happens there. The whole segment is excited, and all the nerves that come out of there come out from an excited root here. The nerve root's excited. So all the nerves that come out and have a motor influence will go to their target tissue, which we'll speak in a second, with more electricity, and it will create dis-ease at these target tissues. So what are these tissues? There's 6 of them. We mentioned a few already. Go on.
Do you mean like ligament?
Yeah, ligaments. That's what we call the sclerotome. Ligaments, all the joint structures. Yeah, same, sclerotome. Connective tissue, the sclerotome. Say again? Organs. Viscerotome. Any others? Bones. Osteotome.
Would you put muscles in that?
Myotomes. There's 2 more. Oh yeah. Say again? Blood. Very good. Arteries, to be specific. The veins aren't innervated. Arteriotomes. Now, let's see if you can find the last one.
Would that be skin?
Skin! Oh my god, this has never happened before. Dermatome. Wow, you did it. So the motor, the nerves, there'll be 6 different categories of tissues it's going to innervate, and it's going to create dis-ease in all 6, no exceptions. All 6 are going to be buggered up. Now, this to me is the key of osteopathy, all this bit. Just that page, forget the rest. No, that's the key. Because here we're in a system now of healthcare that's all about separating. You've got a dermatologist, orthopedic, neurologist, the internist for the organs, cardiologist for the blood, okay, for the arteriotomes, the arteries, okay. And they don't talk to each other because actually it's all about expressions, it's all about symptoms, it's all about the end product. It's like, oh, I've got high blood pressure, go and see the cardiologist. Okay, so we can have a heart issue that's giving us symptoms, but the cause might not be the heart, as you're probably starting to get now. Could be anywhere. You can have back pain here. So you've got the muscles, myotomes. That's the muscles that are locally there by the nerve. So you'll have a small spasm there, which you might or might not feel, but there will be a density in the muscle, which will twist the vertebra, and that's your predisposition for back issues. Pick something up, that's predisposed, slightly twisted. Maybe you went running the other day, loaded this up even more. It's already a problem. Loaded more, wearing new shoes maybe, even more loading, putting this out of stable, more. So this is functional. This is not just something that's static. You load this more, there'll be more information in that L4 nerve, and there'll be more electricity going into there, and there'll be more electricity coming out to all 6 tissues. And then you go down and pick something up, it's like, oh my god, this is what's caused it. Whereas it's not. It's this bit. If we get rid of that, then the whole thing goes away. So easy. It's amazing. Okay, so that's the myotomes, the muscles by the spine. But it also innervates some muscles down the leg for that one segment. Okay, the low back innervates leg muscles, the neck innervates arm muscles, the thoracic spine innervates the chest muscles between the ribs. So there'll be some muscular issues down the leg. Typically the quadriceps is the main one. This one. Okay, muscles, bones, same thing. It'll innervate the bone, the vertebra itself, and more the tibia bone as well as the ankle. Hence why, since we buggered up our ankle, it's the L4 nerve. The L3, for example, is more the knee. Okay? The L5, sometimes ankle sprains can cause an L5 issue because it's not it's a map, but it's slightly different with every different person. But yeah, more the foot is the L5 nerve. Okay? Viscerotome, so that's really interesting. It'll also affect the organs. So typically that's more the colon that's affected on one side or the other. Okay? Could be the small intestine as well. And there's a nerve that comes out of there, blends with the L5 nerve, and then blends with all the nerve of the sacrum to innervate all the pelvic organs. So it's going to have a small influence on the pelvic organs. Okay? All right. And the arteries, it's always the same level there. So it'll be where the aorta bifurcates into the two celiac arteries. It'll create a slight density in these two arteries. So this is the bit we can pick all of this up. Oh, and the skin, that's amazing. None of this is published research. Hasn't been published yet, but the research has been made. That's the only one that's been published. It's just the way it is, for good reasons that it's not published yet, but it will be. This is the only one that had to be published, so it's published. And it's amazing, where the skin has dis-ease or ease, the flexibility, if you test it. If you have a look, and when we train osteopaths, we go, oh yeah, can you feel this? And it's really obvious to feel. So that's one of the tissues there. Innervates the skin. Right.
Can I just ask?
Yes.
Where, in this example, where would the skin be affected? Would it be in the region of L4?
Yeah.
Or the ankle, or both?
So that's the most known, out of all the 6, that's the most known, used in neurology to ascertain whether there's a disc prolapse or some sort of entrapment on the nerve. And what we do, we test with a pinprick to see the pain sensation. It's the most accurate. Sensitivity as well. So an L4 tends to be the front of the shin and in the inside of the ankle, that patch of skin there. L3 will be wrap around the knee there. L2 is more the middle of the thigh. L1 is the groin. L5 tends to be top of the foot. S1 in the sacrum is half the sole, and then S2 the other.
Does all this apply to migraine as well?
Yeah, we're going to go into it now. So, well, this is, hold on, we've got back pain here. That's the end result. Migraine is also the end result. So what I'm going to say is that we can have an end result here, but the cause could come from anywhere. Because just to finish this, L4 nerve synapse is there, information goes up to the brain, and then the brain reorganizes the whole system around that one ankle. In fact, I saw somebody yesterday with an ankle issue, and she had about 60% on her weight off the ankle. She had other issues, but yeah, that was one of them we had to treat. Okay.
If somebody's in that position, would that affect their mind?
Yeah, it will. She's yeah, she does a lot of yoga, and yeah, but we don't know what's going to happen with their balance. So she felt more balanced on the ankle that she twisted and she had a problem with. If she goes on a good ankle, she felt quite wobbly. For me, I mean, it sort of made sense, and it'll make sense to you now. Issue there, tension in the muscles there. So we've got tension in muscles on the right. And in order to take your left foot off, you have to have some contraction that happens from there and to the hip there, otherwise you'll fall over. And plus, she's stuck generally in the right side bending. So when she does the other way, since that doesn't get better because the ankle needs to be sorted for the tension there to get better, it's much harder. So it's the balance to do with the whole thing. Good. So, migraines could come from anywhere. However, There's something that I've always seen, two things I've always seen with migraines. Oh, wait, before we go into that. Sorry. Headaches, the less severe one, headaches, not migraines. So if we take our C5 whiplash problem, same thing as this. So this time it's the vertebra itself. The body's decided, yeah, we're going to lock all this stuff up. It's going to create tension locally, which will have to inevitably spread up and down through the muscles of the neck. And that can start our tension headache or cervicogenic headache. Okay? For example. Right. Before I leave this, we're going to get onto migraines. So this is all well and good. But the question is, when you see this, here I've done the work for you. I've said, well, it starts from here, this is the story. But in real life, you see somebody with all sorts of issues here, there and everywhere. So how can we work out that it's coming from there? Or that it's coming from one vertebra? That is osteopathic training. That's what we teach osteopaths. But basically, as I said, this is a functional reaction. Put weight onto there, pressurize this, more electricity through the nerve, and then motor, all of these tissues connected to that L4 will get worse. So if you feel the L4 skin compared to the other side, pressurize the ankle, make it worse, threaten it, as we do it in a technical way, then the skin will actually get worse on this side. Okay? And you can threaten the L4, which is just a compensation. So if you take something that's necessary away, everything else will have to do more work. So then again, we can test the skin, we can test the colon, we can test the bone itself. That's the easiest, hence osteopathy. So then we know, cause and effect, we can interact with all of this. So if we start to help the ankle out, oh, the L4 gets better. Fabulous. And there was a compensation in the middle of the back as well. That also gets better. And the shoulders were twisted because of that. And that also gets better. So we know treating the ankle will get a few things better. Maybe the whole system. Again, we test for that. So this lady yesterday, she had an ankle and she had an organ. I can't remember which one. I think higher up. And treating those two bits meant her system was balanced. Right, so migraines now. So now you know the theory of osteopathy. So migraines, yes, could come anywhere. It could come from anywhere. However, there's two things. One of them's theoretical, but that also happens all the time. Welcome back. So I said before, didn't I? It's the neck from C3 to C7. Nerves from there, that goes through the spine and innervates the head. So somebody suffering from a migraine has to have an issue there. Doesn't mean that's the cause, but there has to be an issue there. To bugger up the tissues in the head, this also has to be expressing buggery or dis-ease. The other ones is T1 to T4. That also has to be there in order to disturb the tissues in the head. That has to be involved. So again, we'll feel it with the bone, with the muscles, and all the 6 tissues. Okay? So step in the right direction, but that stuff could come from anywhere. So we had our L4 problem with the other thing. That will create compensations there. So yes, there has to be issues there. So that's number one, what I always find. There's issues there. Doesn't mean that needs to be treated directly, but it definitely needs to be released by tracing down what's causing it. Now that's the theory, which I can back up with my observation. But one thing that I found, just observing in clinic, is something there with migraine sufferers that's always there. No exceptions. So I love working in this way. So rather than go, oh, you got migraine, this is the protocol, we stretch this and we crack this and we do this, and then this is your symptoms, the end product of a process, and we're going to base a whole treatment around that. For me, it's like, okay, that's fine, and we're just going to put that aside. Now the tissues know, the neurology knows what's happening inside, so let's ask the tissues, you know. And then This is what I find is like, people who suffer from migraines always have an issue in that area. What do you think that is? Yeah, liver. You got the right lobe of the liver and the left lobe of the liver. Did you know that? It's split into two. You've got the gallbladder in the middle. Right lobe does more digestion, and left lobe does more detoxification. Which one do you think is always the problem, left or right? Left, right. Yeah, left. Always. I always find this. Not necessarily on the first treatment. Sometimes it comes up on the second, rarely on the third, but it happens. But it comes up early on. Okay? And I'm going to go into why I think that makes sense. But first of all, you know how it goes now in osteopathy. You're better trained than most osteopaths. Nerves to the liver. If that's a problem, if this has had an impact, you've had a car accident, you've got the seat belt, mechanical impact into the liver. So it could be a mechanical impact. That's the only impacts we've spoken about. There can be physiological impacts as well. So that's demand on the physiology. So that's the detoxification part. So a toxic load will be a physiological demand and impact onto this. And then the neurology can react. So, nerves to the liver. No, different colour. It's T6 underneath the shoulder blade there, down to T9. Okay? T6 to T9. So are we going to have a problem in these bones? Yeah, sure we are. Are we going to crack them? No, we're not. Because you know what, if we do that, this is necessary, there's tension in the back, and it'll make the liver worse. And it doesn't have to, but it might give us a treatment reaction. That's a very political thing to say, treatment reactions. It means, it's just a reaction, rather than, I've just buggered you up. Treatment reaction, such as headaches. That's a common treatment reaction. So if we take away what's necessary, this is the mafia. This is the mafia. We've got the boss of the mafia here in this example. If you kill anyone else in the mafia, that's not the boss is going to be angry. This is the cause, and it's got its effects left, right, and center. Take away the effects, the cause will get worse. Because the effects was there because of the cause. Okay? So anyway, that's just a side bonus thing. So we've got issue there, and the other nerve that innervates the liver, do you know? Anybody know? That's the sympathetic nervous system, and then we have the parasympathetic nervous system. It's the longest nerve in the body. The vagus nerve. It's a buzzword as well, which comes in at the brainstem. It's the 12th cranial nerve. There's only 12 cranial nerves. It's the last one, lowest down in the brainstem. And that affects our C1 to C2 right at the top. Same as this. We'll have a problem up here. Have you heard of vagus nerve therapy or vagal therapy or vagus nerve stimulation? No? Nobody? Okay. Well, it's a new thing. It's in the last 5 years. It's you will hear of it. You will. Because it makes really good results temporarily. And this will be a classic case. Sorry, so we've got the nerve. It winds its way around the heart, in the neck, and then eventually goes in here. And they usually do the therapy around here. And they make the nerve a bit better. So if the person's got a liver problem, all that area is compromised because of the vagus nerve. Make the nerve better, the whole area loosens up. But of course, the cause stays there. So things feel better. It's like, my headaches are better. Thank you. And then obviously it comes back because the nerve is just a phone line. Occasionally you get nerve problems themselves, but that's not that common. So it's just a phone line. So we make the phone line better, but eventually, and it doesn't take long, it takes a few days, this eventually reinstates the whole communication and the whole problem comes back. So when you hear about vagal nerve therapy, yes, it has great effects, but they're temporary. Right. So neurologically and mechanically, we're already setting up the scene for having issues higher up. But physiologically, I think, is the key for migraines. because what's the difference between a migraine and a hangover? Does a hangover last half an hour or an hour? Can go on all day. Can go on for a couple of days. Everybody says, oh, it's dehydration. When I was about 20, I went to Midsummer celebration in Sweden, 21st of June. Yeah, it was a bad idea. There was a bit too much absolute vodka involved. That's what they did over there. They drink it like there was water. Yeah, I did not fare well with that. It took me 2 days to recover, regardless how much water I drank. So, yeah, okay, dehydration is one thing. Alcohol is a diuretic. It makes you dehydrated, like coffee, like tea. But, yeah, there's something more. Okay?
It's a poison, isn't it?
That's it. Yeah, it's a poison. So anything that's a poison, synthetic sweeteners are poisons. Fructose. Anybody heard of fructose? It's great because it doesn't stimulate the pancreas to secrete insulin, because it doesn't go into the whole digestive tract, because it's a poison. So it actually goes to the left lobe of the liver. So of course it doesn't cause any insulin issues because it doesn't even affect that system. It goes to the detox system. Fructose was really, 20 years ago it started being hype. Now, people say, well, okay, not too much fructose. That's not fruits and stuff. Fruit is fine. Anyway, so detox, hangover, you wake up, you're irritable, you're sensitive, no patience, headache, maybe pounding, okay, and it can last a while. And to me, I know it's not the same, but to me, it's similar. So if we look at all the other headaches, we had tension headaches. Oh yeah, when I'd stretch my neck, oh, I get the pain there. Or if I look up, or I do work with the curtains, or I look up at the fireworks, then I get the headache. And then I give it a massage and then it gets better. That's all mechanical. It doesn't last for 72 hours or 4 hours. Okay, so to me, migraine is very physiological. There's a chemistry involved. Okay. Like there is with a hangover. That's chemistry. Except if you went in the marsh pit, you're not going to necessarily have a mechanical issue with your neck from, drinking too much. Okay? And I think that, this is just working backwards of why am I keep on seeing this with these patients? And why does treating this make such a massive difference to migraine? That's the other thing. If it didn't affect migraine, then who cares? So that was the questions that I had. It's like, wow, this is amazing. And also, the other thing that was the giveaway is smoking, particularly with cluster migraines. I've had many patients who, when I asked them their history, go, I used to have cluster migraine, but I don't anymore. And I was, what do you mean you don't anymore? That doesn't usually happen. And a lot of them say smoking. I'll give up smoking, and within a few weeks or months, I didn't have any more cluster migraines. Most people who have migraines don't necessarily smoke, but smoke is a poison, and it will affect this bit. Okay? And there's something funny that happens with detox. There's 3 stages of detox. 1, 2, 3. Phase 1 makes toxins more irritating, but it has to do that before they can go to phase 2 to be rendered less irritating in order to go to phase 3, which is elimination through the skin, the lungs, colon, and bladder. So urine and feces. So instead of having irritating chemicals going through these elimination pathways all the time, let's render them less irritating. But before they get less irritating, they're reacted with, the process starts, and they become temporarily irritating, more irritating. And somebody mentioned minerals. They're very 2 different processes because they're 2 different chemistry reactions. And if one is lacking certain resources, there will be a bottleneck. There can be a bottleneck at the second one, which means you end up having toxins in your body that are even more irritating than they would be if they hadn't been interacted with in the first place. Okay? Anyway, that's detox. Now, so we've got the neurology that will affect the mechanics and affect the tissues causing pain. And then there's the physiology. So toxins flowing all over the place will be irritating to all over the place. But the brain is slightly more sensitive, number 1. Has a blood-brain barrier. So most toxins actually can't go in because it's an important part of the body. But some toxins still can. Have you heard of VOC, volatile organic compounds, to name one? Now, if you buy paint somewhere, they'll always say, oh, low VOC or VOC-free, because that's really toxic. It goes through. It's solvent-based, which means if you breathe it in the lungs, in the bloodstream, and because of its nature, it goes through the blood-brain barrier, and can cause a headache right away, because it irritates, okay? And I think that's what happens up there with migraines. There's that semi-constant irritation going on because of the lack of detox. Okay? There you go. Because of the lack of detox, backflows in the system, mild irritation in the arteries more than anything else. That's where things travel into. Now, if we irritate these tissues, like the ankle impact, that's one impact, or you can also get many small impacts, like repetitive strain, that sort of model. So if we just generally irritate there, we'll get lots of impacts, and at some point the neurology will go, oh, hold on, this is always happening, we need to do something. And it will lead to dis-ease eventually. That's what happens. If the neurology gets involved, it'll always amount to dis-ease, to tensions, density in the tissues, which will make this even worse. So I think that's why detox nearly always help migraine sufferers, and resolving that bit in the liver, which will then enable all the detox to work properly. It'll enable the liver to work properly, and as long as the person has got the right resources to do the right job, then it usually makes a massive difference to the migraines. But there is never one cause. So that I always find. I haven't found the exception yet. Maybe I will one day. So that's number one, and that's number two. Nearly always, I can't think of one case, doesn't have an issue around there, especially the T1 to T4. Because they're the nerves that are going to innervate up here anyway. Okay? We could have toxins, irritates up there, and then up there becomes a problem, same as the liver, second issue, and that will affect the T1 to T4 as well as the neck. Interestingly, the organs, all organs, are connected to the diaphragm. If it's a pelvic organ, it'll attach to the other organs and eventually indirectly attach to the diaphragm. But eventually, all organs are attached to the diaphragm. So if we have an organ issue, tension in one organ, it will obviously pull on one side of the diaphragm or the other. Anybody knows the nerve to the diaphragm? It's called phrenic. Anybody knows where it goes? So from the diaphragm, winds its way up and goes into C3 to C5. So that's just an add-on thing. Liver issue will cause a nice bit of, same thing, facilitation, nice bit of tension in the C3, 4, 5. All right. So we can't expect to be healthy if we've got that going on. There's bound to be dis-eases in places which will generate symptoms. So here, that person doesn't have to have headaches. So that's the beauty of it. We can focus on symptoms, which is the end product of a process, or we can put the symptoms aside and let's have a look at what's happening. Let's have a look at the process. And just to state one example, the liver will typically happen with tension there. The brain will coordinate all of that, but we'll have tension going into the iliopsoas muscle, so the right hip. That muscle does this movement. Okay? It attaches in the hip. There, that attach in the inside of the hip. That attachment carries on down through the adductors muscles of the thigh that do that movement. Abductors, adductors, attach in the inside of the knee, and that carries on down with tibialis posterior, that goes underneath the foot. tibialis posterior, that goes then underneath the foot. And when that tibialis posterior muscle tightens, we get a slight supination. And here, this is perfect for twisting your ankle, because it's already preloaded in that movement. So then if you do twist your ankle, there's already an issue there. That sets up more chance for the ankle to be a problem. I'm just saying the ankle because we covered that already. Okay? So maybe the person's coming in with a knee issue, because that will have to directly compensate. And yes, we might find an ankle issue, and guess what? Find the one that was there before, the liver issue. Maybe. The point is, if we go, you got a knee problem, you're saying you got a knee pain, okay, let's treat the knee. Then we miss the whole picture of causality. Okay? Any questions at this stage? Yes, sorry. Yes, go on.
It really makes sense to me, this. I was just wondering if you could explain why my migraines get worse when I go to sleep, when I lie down.
Interesting.
When I feel really tired and I really want to sleep, I actually feel worse having sex.
Interesting.
I end up feeling a lot worse usually.
Yeah, so the sleepiness is almost expected. I think probably a lot of migraine sufferers can coincide with that. It's like, when I get the migraines, I'm just exhausted. It takes it out of the system because it affects up there. One thing that happens, so if we have any irritation anywhere in the body will go, that's getting irritated. Well, so it's being damaged. That's the definition of irritation. The tissue's being damaged or compromised. So let's bring the stuff we need to bring in the area to heal the tissues, and that's called inflammation. So the stuff is called inflammatory mediators that the body produces. So if we've got irritating chemicals accumulating up there, and we might have other stories, that means that it will accumulate up there more. Yeah, something I forgot to say. So drainage is key. If you've got lots of toxins, if you can drain them quicker, you'll have less accumulating. So we're going to go into that now. And tension in the top of the neck, right there, is key for blocking up the drainage of the face and head. Which is why this is the classic osteopathic protocol, which is not osteopathic at all, because it doesn't deal with causes, of, you've got headaches and migraines, good, let's just stretch these suboccipital muscles, which will help the drainage, and it might make them better temporarily. It might make them worse as well. Okay, so drainage is key when it comes to toxins, which are chemicals that irritate tissues. Okay? When you're sleeping, what happens? Apart from... Yeah, everything's stasis. Okay? And all our blood vessels, all our fluids, not just the blood, the lymph and all the interstitial fluid and the cerebrospinal fluid, everything becomes more stagnant. So instead of things getting flushed around, it becomes more stagnant. No, because you're still stasis. So then things become stagnant, which means the irritating chemicals irritate more because they're stagnant. Instead of being flushed from the head, you're walking, you're moving, you're dancing, everything's moving better, everything's functioning better. I've seen that a few times now. With people who go off on pilgrimage walking, they have the wrong lifestyle, don't sleep well, they sleep on poor beds, and they're feeling amazing just because they're walking all day, every day. It's amazing. Movement is life, and life is movement. So when we're sleeping, the blood pressure goes down, the blood flow goes down. So the setup would be, say this is the case with you, liver causing irritation up there, that will get worse. The irritation happening up there then will get worse. But for some people, it does the opposite. They can sleep it off. Migraines usually is not massively affected by sleep. A lot of people wake up and is like, that migraine that started last night is still there this morning. But yes, so sleep, ideally we're there for 8 hours not moving. But, I find the same with patients, they've got low back issues. If there's an inflammation process going on, sitting on the sofa for as little as half an hour could start things to get worse in the low back because they're not moving. A lot of people wake up in the morning, oh my God, it's so much worse in the morning, but then you start moving and after 10-15 minutes it starts to loosen up or get better. So I don't know if that's what's happening. This is just an idea. I always say the proof's in the pudding. When our patients leave the room, it's like, well, we'll see what happens now. It makes sense. Well, we'll see how you feel now and tomorrow and the day after that. Any other questions? Yes?
Do you have success with TMJ? My
Yeah.
partner has it quite badly. A scene specialist is going back soon to another specialist. But he's in a lot of pain, a lot of spasms,
So,
regularly throughout.
so that can't help. Accept it, because the specialist is a TMJ specialist. They specialise in that bit, which in your husband's case, that's the end product of a process. So if it's not coming from there,
Yeah.
they can't help.
Yeah, that's what it feels up to a tooth, up to
Could be teeth.
the jaw.
Yeah, this week I treated someone's tooth. It could be anywhere. The point is, it could be anywhere.
And down to the shoulder.
Because that's where it feels it. So that's the expression. That's the end bit. That's what I mean. For me, it's important to take these details for safety more than anything. But then we just need to get rid of them and go, well, what is actually happening in that body? Oh, there's this, that, and the other. And how does, like for example, liver, ankle. Okay, we've got these two issues. How does that link up with what you're feeling? TMJ, for example. Let's have a look at what we find in the TMJ. There's bound to be mechanical issues in his TMJ, otherwise you wouldn't have pain there. So let's have a feel of the mechanics there. Oh yeah, look, there's problems, that's tight, and that bone is dense. Okay, well if we treat, say he's got that pattern going, it's left lobe of the liver. Oh look, the TMJ relaxes. Almost 100%. And then if we go to the ankle, that does the last 10%.
He has had a lot of injuries. Like, fell out of a tree and his arm.
Oops.
And this bit accident.
Fab.
And jarred everything up. Jarred
Great.
right up to the door, and has had other injuries.
That's great.
Compounded us.
Exactly. Oh yeah, that's it. I mean, when someone comes with migraines, usually there isn't just one treatment to do. Oh yeah, let's treat the liver and whatever other bits lurking around. Most of us don't need just one treatment. I tend to see about one person a year who's just one treatment. Last one was a meditation master doing Tai Chi. Yeah, it's, I mean, it's just one of them things. Most of us need a handful.
Yeah.
So there's layers. We see the first layer, the most taxing layer for the body. It's like, oh, look at that, there's liver. Okay, let's get rid of that. Let's let the dust settle, let the body integrate. Let's have a look in 2 weeks' time, or whatever. We test that as well. One important principle in osteopathy is test, don't guess. There's an optimal time to see someone again. There's the optimal thing to treat, and there's the optimal way to treat it. For that, if it was a seat belt issue, like we said, mechanical input, we need to treat it mechanically because that's the level at which the input came in. If it's more to do with the chemistry, so the detoxification, we need to treat it more on a chemical level. We need to go in the organ and make things move better inside the organ. It's a very different treatment. And then there's other things, other elements. So I don't know what's causing this issue. That's impossible.
Treated people.
Yeah, oh yeah, tons.
Had
Tons.
success.
Tons, yeah. I can't help everyone. Sometimes there's always the odd one, but yeah, that's if the joint's not working properly, we have to find out why. Where does it come from? What is the main issue in that person's body, and does it affect what they're complaining of? Anything else? Go on.
How do you treat the liver as an osteopath? Because
Okay.
my experience is kind of like a massage manipulation,
Yeah.
maybe a crack.
So that depends. That depends.
Detoxification is obviously
That'll
an organ. Is
That'll help massively, okay? Yeah, but depends why that's there. Depends, that dictates the treatment. So test, don't guess. So if we go and treat there, oh look, that gets better, the pelvis gets better, shoulder girdle, it all starts to unwind, great. And there's loads of tests that we do to make sure that that is what we need to treat, to make sure it's the cause, because that's the most important thing. If we don't treat the cause, then we're just destabilizing the whole system. and then there'll be treatment reactions, which we don't want. So, okay, number one, location. That's the right location to treat. Number 1B is where exactly in that left lobe. There'll be a point somewhere in the liver where that's the bit that everything's revolving around. And then the second bit is how do we resolve this? So as I said, if it's a mechanical input that went in, we need to do a mechanical treatment, which is what you were saying. Massaging, moving things around, that's mechanics. Parts moving is mechanics. So if that's the liver and we move it, we're not going to move it that much, but that's the mechanical treatment. There's so many techniques that we can do that. Then we can test which technique we need to do in order to fully resolve it, because that's what we want. We want to resolve it. We don't want to have to treat it again. Treat it what is there? It's a reaction. The neurology makes that tension. Every second of every day, it makes that tension because the neurology reacts to whatever happened before. So with the ankle thing, if you twist your ankle, we're not treating the twisted ankle. It's the neurology that reacted that's making things tight. So it's actually a reaction to the event. So we're not treating the event, we're just treating the reaction that's there. So if we get rid of the reaction, it goes straight away. If it's been there for many decades, it'll take a little while for the tissues, but most of it will clear. Okay, so mechanics, but maybe physiology. So physiology, it's what we call functional osteopathy, dwells into a more structural, there's mechanics, clicking things typically. Functionals, it's not quite cranial osteopathy, even though that's the functional is on the way to cranial. It's a bit confusing, even for most osteopaths. But yeah, it'll be more of a softer approach, and it's an approach based in fluids, because our chemistry is in fluids. Okay, so it's all about. So if that's on a fluid level, so we've got ice, water, steam. Okay, if that's more watery, on a watery level, it's in the fluid. So the ice would be more the mechanics. It's hard. You can throw it. The water is hard to grasp, but you can, that's the basis of swimming. You can adapt yourself now in water. So we're going to adapt ourselves to the medium around us. So we're going to have more of a fluid palpation. Okay?
And when you say detox, I think a lot of people would think in terms of a diet detox.
Yeah.
That's not what you're saying, is it?
I mean, yeah, it's everything. So it's the air we breathe, the water we drink, the things we put on our skin, the food that we eat, the drinks that we drink, that all accumulates. The plastic in the carpet goes up in the atmosphere, and we breathe it in. And that's why there's, I think there's a problem somewhere, because human health has never been worse than it is now, So I think we have to look, and I think that's got a lot to answer for, because, that's what's changed. All this synthetic stuff, from the food to the water to everything that's in our environment, the pollution, and this all adds up to the toxic load. Doesn't go through the digestive system and get digestive to try to get resources from it, and eliminate the rest that we didn't need from it. It goes to the poison pathway, or the detox pathway. So that typically, this is a common issue, not just with migraine sufferers. Not everybody has that, but a lot of people do. So yes, detox, some people, they stop gluten. It's like, my migraines are much better since I stopped gluten. Gluten, for them, with their constitution, not with everyone, but added demand onto the area. Okay? The diet helps, getting the right diet. But that's not just an hour and a half presentation, the right diet. Still working that one out. And we should be, because we change all the time. Any other questions? Anything I've missed out?
Just sticking on that, sorry.
Yes.
Quickly, I saw a neurologist like 2 years ago, and I went to my doctor recently, and he put me on a preventative, which is vitamin B2.
Okay.
Well, is that doing any harm?
Don't know.
You don't know.
Has it done any good though? That's the question.
Well,
First, do no harm, but
how
yeah.
long do you stay on it to work that out? That's what I thought.
I don't know. This is always the thing. When you look at causes, so, you get the flu. Why do we get the flu? Is it because of a lack of vaccination? Is it because of a lack of drugs? Why do we get infections? Is it because of a lack of antibiotics? Why do we get migraines? Is it because of a lack of painkillers? So is that what we should be prescribing? That's the cause? It's not the cause, I'm sorry, but it can't be. It doesn't make any sense. Okay? It's just, suppressing symptoms, and this is a step in the right direction. Well, how did they test the vitamin B2? Okay, so there might be a research somewhere going, that might help, let's try it. And it might help. But it won't resolve something that's been impregnated in the system. Imprinted in the system. Yeah. Generally speaking, it won't. Yeah. But let me know how that goes. Anything else? Any other questions?
Could you comment on genes now?
Oh yeah, genes. Wow. Okay. So, good. We've got a handful of minutes. Genes, anybody heard of epigenetics? Because that always puts genes in the right context, no? Epi, I'm going to write this down very briefly. I'll have to be brief. Epi, genetics. So genetic, we know what that means. Epi means? Around, yeah. So the bit that's around, or the bit that's more superficial, or what makes more sense here, the bit that's above. What's above the genes? I'm probably going to cut the whole story short. So instead of a story, you'll have just the end. Bruce Lipton is the first one that really ploughed through. Dr. Bruce Lipton. I'll write it down. His first book was The Biology of Belief, but if you look him up, you'll find that. But his theory, which now is 2 decades old, so this is, I don't know why this is not mainstream yet. It's all about the fact that actually genes, they're more the managers of a situation, of a reaction. So there might be a manager in a company that will act on what needs to be acted, but the decision maker is more the president, the CEO. And it now makes much more sense that the person or the entity in the cell that dictates what reaction is going to happen via the genes is the bit that can link, because a reaction is about you're reacting to something. So the entity in the cell is the bit that can link the outside, where there might be things happening, like the change of weather. If it's more sunny, we need to have a darker skin. So we need to adapt to our changing environment. It's basic survival. So things change outside of the cell, outside of our 3 trillion cells, and also within our body, outside of the cells, things change. So what dictates the genes, the reaction of what the cell's going to do, needs to be something that knows what's happening outside and can control what's happening inside. So if you're the CEO of a company, you're the executive, you're like, oh, the market's changing with this, that, and the other. We better change that. And then tell the manager, change that. And the cell membrane is the bit that makes the most sense. The cell membrane, to the skin of the cell, is what can connect both the inside and the outside and will affect the gene expression in the nucleus of the cell. Because the problem with genes, it's not a problem, but it's the problem's the interpretation. It's like, it's genetic, that's it. I've done a research here, I've done a test that says genetic, so nothing I can do. And that is all about opposing the fact that genes are structures that don't change. They don't actually change, but they get affected whether they're on or off. And they tend to be affected by the cell membrane. And to me that makes perfect sense, because if the environment's changing, you need to change with that environment. Otherwise your survival rates go down. So the whole body starts to change. Like, it's more sunny, so let's grow darker skin, And then you grow darker skin. And then it becomes in your genes. And then you can test this, like, you've got the genes. And then your genes get passed on to your offspring. So if you're darker skin, they'll have darker skin. You know, but to me, it's obvious, isn't it? People in Africa have got darker skin because it's hotter, and they give birth to darker skinned people. It's obvious, isn't it? So the point is, okay, genes is one thing. You get your blueprint, you get your genetic makeup that your parents have given you. They've given you their strengths and their weaknesses, package deal. It's our job to work out which is which. Interesting. So that will contribute to, yep, that's who you are. There's your genetic makeup, and then the way you're raised, which usually by your parents will vibrate in the same as your genes. Okay, because it's from them, which is why it makes studies of typically obesity difficult. Because we say, oh, it's in the genes now. We found some genes. Yeah, but if the parents are obese, there's a reason why they're obese. And that reason will be ongoing when they're rearing their child, and then the child will get the same reason. For example, I'm just saying bad food, for example, bad diet. It's an obvious one to say. But so yeah, there might be a gene thing, but there's also a lifestyle thing. So yeah. So genes, yes, to a certain extent, but they can also change. They're not unchangeable structures. Like bones. Bones remodel all the time. Teeth remodel all the time. It's amazing that. Yeah, and genes also change. So again, it's like, oh, let's just do a test. Oh, I've got the gene. Okay, so well, now I'm buggered then. There's nothing I need to do anymore. It was actually that gene is just, something's turned it on, and it can be turned off. But that's, yeah, if you want to know more, he's the guy that came up with it. Anything else? One last burning question if there is, and then we have to escape the building. Yeah, go on.
On the last page, how come everything you talked about pretty much was, yeah, what I have?
What you have? Is that you there? Well, you're standing right there, there's a gap in front of you, you know, so I tuned into you and you came up. Well, this is more common than you think, actually. Yeah. More common than you think. In fact, I forgot to mention, we had the C5 problem with the whiplash, but if we've got so that could cause tension in the neck and tension headaches, but if you've got an organ pulling on the phrenic nerve causing tension not just at C5, but at C4 and at C3, there's going to be even more tension in the neck and the potential for more tension headache. Any last questions? Yeah, now we have to stop. The building will close soon and lock us in it. Thank you for coming, each and every one of you. This has been really nice. Probably the best interaction I've had since doing these talks, even more than osteopathic students themselves. I think my lovely wife each gave you a voucher. If you don't have one, ask her. She's at the back of the room. She's a herbalist, so if you need some detox advice, she can help you. But yes, we just got some 50% vouchers for the first treatment, if you feel you need it. Safe onward journey.